stoked to have you on. We do have Dr. Tarun Agarwal for tonight, and he is joining us from North Carolina. Did I just get the backwards, or you South Carolina?
North Carolina, please.
Okay, perfect. North Carolina. If you don't know T-Bone, he's a founder and CEO of Rally Dental Arts and 3D Dentist. 3D Dentist is an education platform which has actually educated over 10,000 dentists over the last couple of years, and really dedicated to helping them grow their practice. He's recognized and featured on many news outlets. You probably see him on several dental and dental sleep medicine publications, but probably his most renowned accomplishment is that he has been voted the best dad of the world by 2 of his 3 kids, which I think is phenomenal. So T-Bone, if you want to kick us off, I know we're talking about the business of sleep tonight, how to be profitable in sleep, and someone as educated and experienced as you in succeeding in not just general dentistry, but in sleep dentistry. Really excited to hear what you have tonight. So you ready to go?
Yeah, I'm always ready.
All right, let's go.
All right, thank you, Chad. Good evening, everyone. It is a little past 8 o'clock here on the East Coast, 5 o'clock for those of you in sunny California and the rest of the West Coast. And this evening, I would like to talk about the business of sleep apnea. Typically, I like to do this particular program very interactively. So if you could ask questions, put them in the chat, that would be great. And then I'll kind of go along here, and there'll be times where I'll pause and maybe you'll interact and maybe you'll choose not to. I mean, I don't know what you guys got going on at home. But I think the truth is that dental sleep medicine is probably one of the more difficult things to implement in a dental practice. And for several reasons. One, it's something that honestly we have zero experience in. We didn't learn any of it in school. Number 2, it's something that is not traditional dentistry. It's not fillings, crowns, it's not dental insurance. It's not, what your insurance covers in terms of dental insurance. And the other thing is it's not something that most of us do on a day-to-day basis. And when you combine those things, it can really lead to a lot of frustration. And so my goal tonight is to kind of share how we've been successful in our practice in doing dental sleep medicine. And the number one thing is I like to keep it simple. And I think especially for those of you that are kind of trying to launch dental sleep medicine in your practice, whether that's, hey, I'm doing one here and there every so often, low-hanging fruit. For those of you that are doing 2, 3, 4, 5 devices per month, and maybe some advice or different thoughts for those of you that are doing 10, 15, 20 or more devices per month. We all have a lot to learn from each other. The first thing I will tell you is that the absolute most important thing that we implemented in our practice to bring sleep medicine into its own is having what we call a champion team member. And that would be the equivalent of like a project manager or a department head or a team lead. And this is a person who owns dental sleep medicine within our practice. And it kind of goes through multiple phases. Phase 1 is it's a conglomerate of people, a hodgepodge of people that are trying to do it. You have your front office team that may work with medical insurance or the patient finances. You have an assistant that will kind of do this in between patients and kind of fit it into the schedule, or in my opinion, what's worse would be you let the dentist start doing this, and dentists have a tendency to find a way to make it more complicated. But the challenge there is it's hard for most of us to mentally think about dedicating a team member to run a specific product. And the truth is I always say success leaves clues. And this is how, kind of how all businesses are run. They're run where there's a department head and they're responsible for their vertical of the business. And we treated sleep apnea or dental sleep medicine like a startup within our practice. And so for those of you that have done a startup in the past, you started your practice with 0 patients. You had working capital. That working capital funded the time it took for you to get your practice moving in the right direction. So the same kind of holds true here for sleep apnea. Is I funded a startup within my practice, and we hired or promoted, in our case promoted, a team member to run dental sleep medicine. And this team member runs the entire process from beginning to end, whether that's handling, managing referrals, whether that's working with the medical insurance, whether it's working with some of our third-party partners, whether that's working with our laboratories, whether that's doing the consults, whether that's doing the deliveries, everything, basically everything with sleep apnea. And so there was a time period for a year or two where, I'd probably say 6 months where I was losing money because I was paying a team member to kind of get this going. But after about 6 to 8 months, it was pretty much paying for itself. And then there was a time period for a year or two where we weren't at full capacity. And kind of now at our 6th to 7th year of doing sleep apnea with seriousness, we've reached a point where we're ready for a second sleep apnea team member. That's kind of what our champion is. It's our sleep coordinator. And what they're in charge of in our practice, and probably what I want them in your practice, is our hygiene department referrals. I believe in a 2-step approach to dental sleep medicine. Step 1 is you got to learn how to treat the patients that walk in your practice from within your practice, be a self-referral source. Once you kind of get the workflow under control, once you understand what it is that you're doing and how all the parts and pieces and the process works, I then encourage you to go outside and look for referrals. The risk we take by trying to build a referral-based practice from the get-go is that you're experimenting and you may lose a referral in doing that. So our sleep champion or our sleep coordinator handles all the referrals from our hygiene department, and now probably about 75–80% of our cases are coming from medical practices within our community. Still about 25%, 20 to 25% or so come from within the practice. Our sleep coordinator manages our home sleep testing, whether that's using a third-party service to do our home sleep testing for us, or whether that's home sleep testing that we're able to do within our practice ourselves. Our sleep coordinator also handles all the logistics of medical insurance. And that doesn't mean that they're doing medical insurance themselves. They may be handling the logistics with a third-party biller, which is what I encourage everybody to begin with, is with a third-party biller, so that you're not doing that in-house. And then on the clinical side of things, they manage all the consultation and finances and the clinical portions of the sleep apnea workflow in our practice.
Hey,
So,
T-Bone,
yes,
I got a
sir.
question for you.
Yeah, absolutely.
How long did it take you to go through? You mentioned that ratio, the 25% internal referrals, the 60 to 75% external. How long did it take you to go from that first step to that second step?
For us, probably somewhere in the 4-year ballpark.
Okay.
Before outside referrals outpaced internal referrals. And a lot of that was because I was hesitant to go deep outside. I would kind of get started, and so I held us back a little bit. But I think for us it was 3–4 years. If we need to give some perspective to this, I would say year 1 we probably did 15–20 devices. Year 2 we were in the 50–60 ballpark. Year 3 we started hitting that 60 to 80 ballpark, and by year 4 we were 100+. This year we'll probably be this year we're year 7, we'll be at 250+ devices annually. Wow. Within the practice. And look, the truth of this is what really happens a lot in dental sleep medicine, and I understand this because we do a lot of training, myself and Aaron Elliott, and the challenge in all of this is what I call the runway concept. And there's a runway involved in getting sleep medicine off the ground. And most practices and most dentists give up before they allow that runway to kind of give you enough room to take off. The truth is if you go to a class today, it'll be a month before you deliver your first device at best. Between doing, between creating the awareness, getting the diagnostics done, between dealing with the medical insurance if you choose to deal with that, between waiting a couple of weeks for the lab to get you your device, getting it back, it's a solid month and a half before you do your first device. And that's assuming you have somebody day one to get started on. So I always look back and try to explain to people what would happen if I had quit before the 6-7 month period. I would never taste this level of success that we've had. Yeah, so you got to stick it through. And that kind of leads to the next point here, which is what are the challenges that I've seen in dentists implementing sleep champions. Number one is they're not blocking time. If you want to win, if you want to be serious and successful with dental sleep medicine, meaning to me more than 1 or 2 cases here and there, then you're going to have to block time. This is not something you can figure out how to do in between patients or when you happen to have time, because the truth is we won't have time. You've got to block time. So if you want to implement a champion and you're not willing to fund it from the very beginning as a startup, then what I would tell you is you got to block time. And you can't block once a week. You're going to have to block a couple of hours, 2 to 3 times a week at a minimum, for someone to be dedicated to working your sleep apnea practice. Another area that I've seen struggles in is clinical team members are typically not used to talking finances and payment plans and all of that with team members. So you have to have, oftentimes we think of a clinical team member as the person that can do this. And so one thing that is with dental sleep medicine is and I say these things lightly. It's not that I believe these things, but this is how patients or the medical community thinks about this. We're charging $2,000, $3,000, $4,000 for a couple of pieces of plastic. And so you have to have that capability of helping to make it affordable for patients. The other thing that sometimes I see offices do is they'll make a front office team member run sleep apnea. And then you have non-clinical people attempting to do clinical things. And there's a challenge there. Sleep apnea, you got to take impressions, you got to take a bite, you got to take a special type of bite. That's kind of there. Another area that I've seen practices struggle is they try to do medical billing within the practice. And I will tell you that in the beginning, it doesn't make sense for you to do it yourself. Is it a relatively easy claim? Yes, but there's a lot of paperwork, there's a lot of filing, there's a lot of follow-up that's involved with all of these things. And when you're learning something new, the last thing you want to deal with is tedious things like medical billing. So learn to outsource that, and outsourcing costs money, bottom line. That's part of the game. So like in everything else, you're going to have to spend a little money to make money. Another mistake I see is dentists get cheap about testing team members and loved ones, or they choose the wrong team member to be in this position. So those are kind of the common things I've seen in terms of when somebody says, hey, I want to have a sleep coordinator, what mistakes or what challenges have they had in that? You got something for me, Chad?
Yeah, Dr. Stan Rocksroger asked, can you recommend a billing company that doesn't charge a monthly fee whether or not you have a patient to bill in a particular month? So I don't know if you know anyone off the top of your head.
I would hope that they all charge a monthly fee because, at the end of the day, they got to make money. They got to stay in business and they got to have somebody, most of their monthly fees are, $50 to $100, I would imagine. And then they charge, and then at that, depending on the company you work with, they either charge a percentage of collections, or some of them charge a flat fee for each case submitted. And so, unfortunately, that is part of the game. At the end of the day, if I look at it this way, if we're not willing to pay something nominal like $100 a month to have access to a third-party service, then we're probably not serious about winning, is how I look at it. What I've seen is companies come to the market that don't have a monthly fee. They either get taken out of the market or they move to a model where they start having monthly fees involved with it. That's what I've seen over and over again.
Cool, thank you.
Yeah, no problem. So now let's kind of move to, once you have a champion or however you choose to do that. Excuse me, I should have drank some coffee. I just got back from hot yoga. It sweat me out there. We got to work on your workflow, and you got to develop your workflow, and that's fine tuning the process. And the last thing you want to do is kind of bumble and fumble through this. You don't, and the truth is you're gonna bumble and fumble through it in the beginning. There's no way around it. We're so much better at this today than we were 7 years ago. We're better today than we were a year ago. A year ago, we're better than the year before. But our workflow keeps getting better and better. And here's kind of the workflow that we teach in our training programs is that there's 4 steps to complete sleep apnea treatment for your patients. Step 1 is you got to create awareness. One of the challenges in sleep medicine is most of the patients don't even know they have a problem. People are more and more aware of sleep. They're aware of snoring. They don't really quite understand what role a dentist plays in it. So, we've got to create some awareness that A, we exist and we have a solution for a large percentage of the population. And then we also have to create awareness because honestly, the medical community isn't doing that great of a job. Certainly the primary care community isn't doing a great of a job. I can't tell you the number of patients I see that have high blood pressure, that have diabetes, and no one's ever suggested that they may have sleep apnea. Step 2 is you got to have a way to get a diagnosis. That diagnosis has to be done by a sleep physician. So depending on the state laws and depending on your personal beliefs, as a dentist, I'm a firm believer that dentists should be able to dispense home sleep tests. Or you can use a third-party service to do that. And home sleep testing is getting easier and easier. There's disposable ones. There's ones that kind of just go on your finger nowadays. There's ones that wrap around your body, wrap around your wrist. The diagnostic testing is getting better and better and better. Some are app-based. There's lots of choices there, but we've got to get our patient diagnosed. And once we have our patient diagnosed or getting a home sleep test, to me, that's when we do the consultation and the finances. I don't like to talk to patients or do a consultation without the data because I don't even know if they're a good candidate for dental sleep medicine. I don't know if they even have sleep apnea. Why would I don't even know what suggestion to make to them. In our consultation, we always recommend 4 modes of treatment. And I would argue there's no treatment, it's really management. We don't really treat sleep apnea. The 4 modes of management are the most complicated one is lifestyle change. For most of us to lose weight, to get healthier, to get younger. Choice number 2 is the quote unquote gold standard, which is CPAP therapy. Choice number 3 is a dental device, so all appliance therapy. And choice number 4 is surgery. And then areas that I don't have a ton of experience in myself are some of these adjunctive treatment like orthodontic treatment or tongue zapping or orthognathic surgery, things like that. Although that would fall under surgery, but there are a lot of adjunctive ways to help with that. And then once you kind of get the patient to yes, then we have the treatment portion. And my argument is the treatment portion is kind of the most straightforward part of dental sleep medicine. Again, not to belittle what we do, but basically we make a double arch night guard that's taken in a open and protruded bite position. There's 800 different devices out there, and I'm not here to say one is better than the other. We all have our preferences. I happen to use a lot of the ProSomnus Evo device in my practice. That's my number one go-to device. We also use the OptiSleep device. We also use the Panthera device. So, lots of choices in various practices and how we can do this. So let's kind of walk through the workflow kind of briefly. I don't want to take a ton of time on this, but awareness. How are we creating awareness? I look at 3 ways that we create awareness. 1 is through our hygiene department. 2 is subliminal marketing, and 3 is our general dentistry patients. So let's take a look at our hygiene department. We want to review the patient health history. I teach my hygienists that there's four main things we're looking for. There's lots of others, but 4 main things that we look for. Number 1 is patients with cardiac conditions, high blood pressure, heart attacks, things like that. Number 2 is our patients with diabetes. Number 3 are patients with depression or anxiety or insomnia, all the psychiatric conditions. Or number 4 is our patients with acid reflux. And those are your prime candidates from a medical perspective, health history perspective, we should be encouraging to take a diagnostic test. All our patients that we try to do night guards on, we know that bruxism and deep class 2 bites, some of those dental conditions, large tongues, are precursors or telltale signs for a breathing disorder. And that's one of the reasons our patients are kind of jutting their jaw forward, is to help get oxygen. And then we also teach our hygienists how to do the home sleep testing. What about subliminal marketing? Surprisingly, I would say that every month we get about 2 to 3 devices from subliminal marketing. One are posters, and I'll show you an example here. We have posters, or we started with posters in our practice. Today we don't have posters. We have digital signs throughout our office. We have sample devices so that when patients bring up something, we can show them examples. And today's modern devices don't look anything like some of those 1980s, 1990s devices. They're metal-free, they're crystal clear, they're thin, they're light. They're really as comfortable as something can be. And as a person who's been wearing a sleep apnea device, an oral appliance for 15 years now, I will tell you that from personal experience, they've come a long, long way. And then, of course, there's that digital marketing that we can do through services like RevenueWell or Modento or Lighthouse, or any of the, I'm sure I'm missing some of the other ones out there. So some of that we can do from a digital marketing perspective, but we've got to put that up there. And this is an example of our signboard that we have in all of our operatories and in our practice. We have a vertical TV that flips through various quote unquote ads. We talk about our team members in there. We talk about sleep apnea. We have a couple of sleep apnea signs. One that kind of talks about how it affects your whole body, as you see here. Another one that talks about, do you have a spouse that snores? And so, these subliminal marketing things really work quite well at getting patients' attention, especially when they're sitting there waiting in your room for you to get there. And then on our general dental patients, look at our limited exams, fractured teeth, grinding. Those are, again, telltale signs of sleep apnea. And then, of course, the spouses, I can't tell you how many patients, how many wives come in, or boyfriends, and say, can you help my spouse? And we help one spouse, and then typically the husband will come in and say, maybe you can help my wife, she snores too, but I'm afraid to tell her. And so then they leave us to do the hard work. You're back, Chad.
I'm back. Yep. Sorry to interrupt your flow.
That's okay.
We had 2 questions. So Dennis had asked earlier, how do we screen in hygiene? And I thought you covered that really, really well. Dennis, if you want any more clarification, please let us know. But he also has a follow-up question of where can we get signs like what you showed there? And then we have another screening question too.
Yeah, absolutely. So I'll answer both of those. Where can you get the signs? So I made those myself. It's I want to say those are 55-inch TVs. They're about $250 today. You buy a vertical mount, and then basically we created using PowerPoint. Basically, we created vertical signs, and then that's just basically a PowerPoint or a screensaver running in rotation on those TVs. It's kind of like a menu board that you might see at a restaurant, or for those of you that are males, when you go into some of the bathrooms or the urinals, they kind of have a sign there. Or some of us that fill up gas, they have some of those at the gas stations nowadays. So I think Adam answered Anthea's question here. But the four things again are cardiac conditions, diabetes, psychiatric conditions, and acid reflux. Those are the kind of four main things that I look at. So we've created awareness now, and now we're kind of ready to kind of go to the diagnostics. And really, you know, you got to dispense the HST. I'm a firm believer that dentists should be dispensing HSTs. It's up for debate. I don't know why it's up for debate, but it's up for debate. So do check with your state laws on what that is in your own state. So dispense the HST if you can. If not, use a third-party service. And when appropriate, certainly refer to a local sleep physician. So once you get to that point where you're really developing relationships, you can safely and effectively refer to a sleep physician. One of the things I learned early on is that oftentimes when you refer to a sleep physician, your patient gets lost in the vortex and never shows back up. And then, you know, schedule a consult to go over the sleep test results with your patient. So often, to me, again, I'm no scientific expert, but I think an AHI is a terribly misleading number. I think to tell somebody they're mild, moderate, or severe, based on a number where hypopneas and apneas are weighted equally, I think that's silly personally. And but interpret the results. Talk about oxygen. Talk about how often is the pulse going up? How many times are they waking up? How much tossing and turning are they doing? All of these kind of tell a true picture or a complete picture of your patient's sleep. And then, understand how to interpret the results. Most dentists aren't going to get into scoring or being a sleep tech, but I like to learn how to interpret. What I mean by interpret the results, how to kind of digest them in a human language. In other words, take a test and kind of explain to the patient what's going on. So now that we've got our patient aware, we've got our patient diagnosed, now it's ready to go to the consult and the finances. So before the consultation, we do a benefit check and we can't do the pre-authorization quite yet, but we do the benefit check so that we find out, does the patient have medical insurance? Does the medical insurance have coverage for dental sleep medicine, which they almost always do. There may be deductibles and things like that that get in the way. But then we want to have that done, because what we know at consultation is that one of the most common question is how much does it cost and how can I pay for it? So we want to have that answer of the medical insurance. We want to have that ready for the patient. In our practice, we do work with medical insurance quite diligently. We're in network with 3 or 4 medical insurance companies. It's a route I've chosen to go to make things easier for me. You can, and I know many people that are doing it without medical insurance, so it's certainly possible. And then at that point, once your patient says yes at the consultation, then you schedule treatment. And sometimes we're able to do that treatment same day. And in fact, most of the times we're taking records at the consultation appointment. So Amanda asked a question here. What do you charge for the HST? Do you go through medical insurance? So if you're third partying it out, I would they'll handle all the medical insurance and the charges. If you're doing it yourself, what we are or were doing, we're not doing as many HSTs anymore for I think silly reasons from the state of North Carolina, the dental board, but that's neither here nor there. I don't want to get in trouble, but we were charging $150 for the home sleep test, and that would cover the physician to read the test as well. And that was our way of kind of pre-qualifying the patient. We didn't look at the HST as a profit center in of itself. We looked at it as a way to get the patients in the door to see if they had sleep apnea, and as a public service to our patients as well. Did we bill medical insurance for it? No. We typically did that out of pocket just because then you have to go into the pre-auth. It just becomes a lot of work for a $150 test. If the patient's not willing to pay $150, we're happy to refer them somewhere to go pay more somewhere else to get it done. Now that we've got our patient aware, we've got them diagnosed, we've got the consult and finances done, now we're ready to do treatment. And treatment, again, not trying to make this more simple than it isn't, but basically to make a sleep apnea device, you got to take impressions upper and lower, and you got to take a bite in an open and protruded position. You can do that with a George gauge, you can do that with a leaf gauge, you can do that with a SOM gauge, you can do that by feel, although that probably wouldn't do that. And in today's world, and at least in our practice, this is completely digital. We don't even have this type of bite registration materials in the practice anymore. So, you know, and then we take photos. For us, we want a photo of the patient biting straight on and from the sides, so that when and if there are bite changes, we have some record of where the bite started on our patient. And then on the clinical side, there's also the delivery and follow-up. We have to deliver the device, and we have to do some follow-ups. And depending on your protocols, that follow-up may include a home sleep test on your end, or referring back out for the home sleep test. And again, you know, for the time period that I have here, you know, I can't go into great detail. Typically, a good sleep apnea training is several days long, and quite frankly, a lifetime of learning as you get deeper and deeper into it. So that's kind of our workflow: is awareness, diagnosis, the consult and finances, and then the treatment. And, you know, let's kind of get into some of the nitty gritty of what's going on. So every morning, our sleep coordinator, our sleep champion, as I like to do it, is we'll identify a few patients in the practice from the medical history. And typically we try to identify one per hygienist of a patient that we would like you to bring up sleep apnea with, and ask for a conversation with our sleep champion, Liz, in our practice. So the hygienist is simply making the patient aware that they may have a condition known as obstructive sleep apnea. We highly encourage them to get a test, and that we have a person in our practice who handles and coordinates all of that, with either through our practice or virtually, or with a local sleep physician. And we're simply asking for the hygienist to make a referral to Liz. And Liz does the homework for the hygienist to make it easy for them. And she'll pick one patient each day based on those 4 things that I talked about earlier. Of course, we have to add questions to our medical history questionnaire, because, you know, we want to know, does the patient know they snore? Have they had a sleep study in the past? Have they been told to wear CPAP, and do they actually wear the CPAP? You know, what I was shocked at is how many of our patients know or have a CPAP that they don't use. You know, that's low-hanging fruit for us to convert into oral appliance therapy, because what we do know is some therapy is better than zero therapy. Then we talk about, you know, picking targets, and, you know, some of us may take offense to the word target, you know, and it's, you know, for me, I want to choose a target that's closest to me. And that means the easiest one, the lowest hanging fruit. And the lowest hanging fruit to me are the patients that have multiple of those 4 medical conditions. The more of those medical conditions they have, the more likely they have obstructive sleep apnea. So why would I choose a patient without medical conditions to talk to versus patients with medical conditions? And then, of course, talking to patients you have a trusted relationship with is even easier for that. So, you know, try to take a look at that. We keep what we call a book of business. You know, with cold leads, that's people that we are cold, like we bring it up to them. They didn't come here talking about it. That's from the medical history of the questionnaire. All the way to our hot leads. Our hot leads are our patients that already have dental devices, oral appliance therapy, and we try to do a recall on them every 2 to 3 years where they're ready for a new device. Typically, their medical benefits will pay for another device, and that's another momentum builder in the practice. The more we do this year, the more we'll get to do 3 years from now. In addition to the new cases we get, we'll get a percentage of our old cases. to do. And then our warm leads, and our warm lead are people that we've taken down the funnel, people that we've gone from awareness to getting tested, maybe money got in the way, then we keep them on a list and we restart rechecking benefits in September, because they've used up the deductible or they've met the deductible, they met their family out of max. So that's there. And we had a question from David, do I use a morning positioner for the bite? Yes, we provide every patient with an AM aligner for them. We encourage them to use it. I'm, as a patient myself, I can tell you I haven't used my AM aligner in 14 of the 15 years I've been using my device. I do have a little bit of an open bite in the morning, and about this time at night is kind of when it comes back together. Another area that's super important is to have a financial menu. You've got to find a way to make this affordable for your patients. And that's kind of where I'd like to kind of take the end of our conversation, because that's where the rubber meets the road is, we can be great at creating awareness, helping them get diagnosed, doing all the clinical part. But at the end of the day, we've got to find a way to make this affordable for our patients. And to me, nothing makes it more affordable than having payment options and having a financial menu in place that transparently gives it to our patient in writing. So if you guys give me a moment here, I'll actually pull up and do a live demo of our financial menu here. Give me a moment here. Hopefully you guys are seeing my financial menu there on the screen. Is that correct, Chad?
Yes, it is.
Excuse my language here. So, what we'll do here is we'll say the fee is, let's just say it's $2,200. The patient is paying completely out of pocket. So our team member puts this in and it pops out all the different ways that our patient can pay for this. So the patient can, they can pay us up front if they'd like, or, they can do a payment plan as little as $42 a month. They'll be paying for it forever at that price point at 7 years. But, something like this can, $100 a month is very affordable for a lot of patients. So, having a financial menu like this is very helpful for the patient. So even if it, what I found with this is that we can suddenly start making things a little bit higher in price, but yet still more affordable for our patients, which helps us increase profitability in our practice in doing that. You're back, Chad.
I am. Yeah. I mean, just as a personal question as a coach is, who offers that 7 years of financing?
Yeah. So some of the companies like Proceed offer 7 years, but look, there's a dollar amount at which point they'll offer 7 years. I doubt $2,000 fits in their range of 7-year financing for $2,000. Typically the 7 years is probably getting into the $10, $15, $20, $30,000 ballpark. But there's, I think even Care Credit goes out to I've seen financing up to 9-10 years now. That's being offered, that's available for our patients. Now, certainly there's a discount cost to the practice for doing that. But again, if you want to succeed and win, you have to be open to spending a little bit of money to get that done there. So, we found a lot of success in having a financial menu and offering payment plans. And in fact, in our practice, we will I'm comfortable being the bank on up to a 12 month basis for sleep apnea devices. But we also do work with our third-party financing when patients need payment plans a little bit smaller than that. But the overall message is get started, team and spouses, do the first, establish a first 5 or 10 pricing. When I started, I just wanted to do the first 10 at $1,000 just to cover my cost, maybe even $800, just so we can get some experience. We can get some testimonials. We can get some some reassurance that it does work. Keep track of your book of business. The hard work we do in January, February, March sets us up for amazing success in Q4. And part of that is we keep track of the patients that said no due to finances or some other reason in the beginning of the year, and then we kind of work through those towards the end of the year. Understand there's sleep recall every 2 to 3 years. You can make a new device by medical insurance, and you probably should be making a new device for patients. And then understand the difference in how you treat and work with hot and warm and cold leads through all of this. So that's kind of my thing. And then Chad, I think you guys have some messaging here on this.
Yeah, I do have a couple questions, but since it's up, guys, it's the end of the year, and if you are looking to get started and, and find those patients that you're looking for, we've got a virtual course coming up in January 27th, 28th, and really our calendar coming up for the next coming year. So if you want to scan that QR code, or go to awakensleep.com/events, we're offering a $200 discount for that course just for the end of the year in this webinar. And then T-Bone, if you could go to the next slide for me. We also have the opportunity, if you want to connect with a coach, we talked about some signs and stuff like that. We're happy to just answer any questions that you have. And just, if there's anything related to anything T-Bone's talking about or implementing in your practice with your unique circumstances, your state guidelines, we do that research for all of our practices and just trying to help facilitate you getting started. And then if you just sit on the last slide there, T-Bone. And then I do have a couple questions for you. One, on your leads that you're talking about, and these are just people messaging me privately. You said that for every 3 years, you're doing a new device. Are you charging the same for that new device?
Yeah, I'm not saying we are doing. We're giving the patients the choice to get a new device. Device. Yeah, and so we'll charge whatever our current rate is. Because honestly, we have to go through the process again. We have to take new impressions, we have to take a new bite, we have to do everything all over again. So we do that, and then we will offer to bill that to medical insurance for the patient if those offices that are participating with medical insurance.
Cool. George Bear asked, is it legal for us to charge a slightly higher fee when using a third-party financing versus patient paying with cold hard cash?
That's probably, I'm not a lawyer. I try to avoid lawyers. My older brother is a lawyer, but what I would tell you is my understanding is that you cannot have a higher fee for patients you cannot charge a fee to use third-party financing.
You did have on your form, though, I think a key to that, though, is you can always discount anything you want.
Yeah, right? But remember, if you discount, you also have to discount to the medical insurance company.
Got it. Okay. Yeah. I did not know that.
Yeah.
Cool.
So you can't charge the patient one thing and then bill a different rate to the medical insurance company. So you got, look, here's what I'm going to tell you is this discounting is unnecessary if you find a way to make it affordable for your patients in terms of monthly payment plans. You can actually charge more for your dentistry. And that's something that we work with a lot here at 3D Dentists.
Awesome. Another question, very specific circumstance, but I have 1.3 million per year general practice. I want to start screening. How many home sleep tests do I need to buy?
First thing I would say is double check that you can do it in your state. And for me, it starts with 1. Okay, don't go by 10. Start with 1, and then every time that you have to make somebody wait, buy another one. These things are like $2,000, $2,500. And so buy 1, prove the concept, buy a second one, prove the concept. Until North Carolina changed the laws, we had gotten up to 5 or 6 home sleep tests in our practice. They weren't all going out at once, but my philosophy in building this part of the business was I never want to say no to a patient that we don't have a test to go out with them. And I personally want the patient to leave with a test today. So I don't want them to wait ever for that.
Awesome. Another question, general business. What's the average overhead percentage for sleep practice? And what equipment does someone absolutely have to do this?
So let's talk about the equipment first. To do dental sleep medicine, you have to have an upper impression tray, a lower impression tray. polyvinyl impression material, bite registration material. I would probably say at least a leaf gauge or a George gauge or some gauge, some type of thing to help you take a bite, or even airway metrics as an option. I would say that's all you have to have. You don't have to have a home sleep test. You can outsource that. You don't have to have CBCT. You don't have to have digital impressions. You don't have to have any of that stuff. In fact, when I started doing dental sleep medicine my first time back in 2006, I think 5, 6, we were non-digital at that point in terms of dental sleep medicine. You couldn't really take full arch impressions with the digital impressions at the time. So you don't need anything fancy to get started. What I can tell you is fancy things accelerate the ability to do dentistry faster. And that's the beauty, and it's more accurate and it's quicker and better.
Yeah. Jordan asks, we get a patient's sleep study back before they come in for the results appointment and we find out they have OSA. Would you recommend to submit for a pre-auth before doing the consult?
Personally, no, because sometimes your patients don't want you to submit that to their medical insurance. For example, we have some of our patients who are truck drivers or bus drivers or train. I don't think you're a train driver, but you're trained something or another, or they're airplane pilots. And they don't want us to submit that to their medical insurance for any number of reasons that they want to hide it or not hide it, or maybe they're getting ready to go to apply for life insurance and they don't want that there. I always want to get patient permission before we do that. Now, I am very comfortable doing a benefit check and a benefit calculation, certainly, because that's not part of their record. But I would not do a pre-authorization without the patient committing to treatment. And the other thing is, a pre-authorization has a timeline of how long it's good for. So if it takes you, several weeks or a month to get the patient back in, then you have to go back through the process again. And frankly speaking, a pre-authorization is quite a bit of paperwork.
Yeah. Jordan, he asked follow-up, if they said it was okay to do it when they took home the home sleep test, I think that's your permission you're looking for.
Yeah. But again, I'm a big believer in sitting down face-to-face or virtually with the patient and reviewing the results of their sleep test, connecting the dots, connecting the sleep test to their conditions, to their, what the chief motivating factors and all of those things.
Cool. Dennis asked in the chat, do you take a CBCT on all your patients?
I do in our practice, all meaning 95, 98% of our patients, we take a CBCT on pretty much all the patients. That's our personal standard of care in our practice.
Cool. Ronald asks, how do you handle a pulmonologist that you work with that only refer their problem patients back to you?
Yeah, I probably stopped working with them. I believe in a world of abundance. And certainly we're going to have problem patients, just like I'm going to send them some of my problem patients. But if it's a one-way street, then stop working with them. Or if it's enough business, just deal with it.
Cool. I do have another. How do you manage to do a GP and sleep? I've heard that you have to do one or the other.
That's absolutely false. You can mix the two. What I will say is that if you truly mix, what I have seen is that you'll probably typically anywhere between 20 and 50 devices a year if you're mixing. And then, our hybrid model that I believe works unbelievably well is the model where we build a sleep practice within our general practice by having a team member that's a sleep apnea coordinator, or as we call them, sleep champions in our practice, that runs that part of the practice. Honestly, I'm living proof of it. Aaron Elliott is living proof of it. There's so many other dentists out there that are living proof of it.
Yeah. I like how direct you are about that. It's just
what am I
false.
supposed to do? Dance around it? It's false.
Yeah. Yeah. Amanda
look,
asked
here is the truth. If you're going to dabble in sleep apnea as a general practitioner, you're going to have a lot of hurdles to deal with. So what I tell dabblers is don't work with medical insurance, charge a flat cash price, and just call it a day. Don't bother getting into the medical insurance game if you're just going to dabble and try to do 1 or 2 cases a month. Just charge a fair cash price and move on.
Awesome. We've got two more questions, and
So I'll take as many as you want.
awesome. Amanda asks, how often do you redo the home sleep test to make sure the appliance is still working?
Yeah, so that's a interesting question. So in our model, we refer our patients back to, 75% of our patients get referred back to our referring physicians for them to do the HST. And our dental board has not made a good, clear ruling on whether or not dentists can even do HSTs for follow-up testing, which I think is it's ambiguous. Before all of this happened, we would do follow-up tests at the 1 month mark with our patients. And what I will tell you from personal experience is that appliance therapy is quite effective, but oftentimes the AHI goes back up. It actually goes up post-operatively. And that becomes from, 1 apnea turning into 3 hypopneas. And things like that, or suddenly the patient gets longer REM sleep, and when they get more REM sleep, they start having more events. So again, back to my whole point that AHI can be a misleading number, and that's why it's important to have good training and good ongoing training, and to really, if you're going to get into the game of dental sleep medicine, get into the game to win. That's and one thing I didn't make mention to, we don't do any snoring devices. We make devices for people that snore, but we won't make any type of sleep apnea or snoring device without a home sleep test. Or some type of diagnostic sleep test. That's what I mean by we don't make snoring devices. We don't make any type of guard, opens the bite, moves the jaw forward without some type of diagnostic sleep testing.
Cool. Paul asked about the CBCT. So what are you looking for in the cone beam? And is a radiologist writing that report? Are you asking for specific images?
Yeah, so we take the CBCT in our practice. Most of the time when you buy a CBCT, they're going to provide you with some type of basic radiology training. We don't have all of our CBCTs read. Professionally read. We have a small percentage of them professionally read when we see something out of line. Typically, my first line of defense when I see something out of line is refer them to a local oral surgeon as pathologist that we have and let them deal with it, make it their problem. They're probably like that pulmonologist that sends them the problem patients. But I think if you're a pathologist, you're asking for problem patients. And then, or in really interesting situations, we'll have it professionally read by an oral maxillofacial radiologist.
Cool. All right, we got one more question, at least, that I had privately. If anyone else has questions, following this question, if there's no more, we're going to wrap up for the night. If you had to say there was one thing that could make someone really profitable in sleep, what would they have to do to will that one thing be?
Yeah, they would need a sleep coordinator. That has been my number one success, is that I have supported, funded, provided the infrastructure to Liz, who runs our sleep apnea practice, and I've gotten out of the way. That's what I would tell you is get the right person, get the hell out of the way, and call it a day.
Okay. We did have Paul submit a follow-up question about the cone beam.
Yeah.
You want to take that?
Yeah, I don't know exactly what he's looking for. If its question is in terms of for sleep apnea, there's nothing you can look for in a CBCT that will tell you the patient has sleep apnea. What a CBCT can show you is a narrowing of the airway. It can be a conversation starter. It can show you what the nasal turbinates look like. It can show you the size of the oropharynx, the nasal pharynx, any deviated septums. It can show you the turbinates. It can show you things along those lines in terms of those things that are ancillary and adjunctive to dental sleep medicine. But in terms of what am I looking for, there's a long list of basically what I'm looking for is symmetry when I'm reviewing a CBCT in terms of pathology.
Okay.
I don't know how else to answer that question for Paul.
I think probably was just related to what you're looking to for sleep.
Yeah.
And it's not, it's not diagnostic, unfortunately, right?
Yeah.
So
No.
it's a screening tool. Oh, are you taking another cone beam for the appliance? That'd be for your OptiSleep, probably.
So with the OptiSleep workflow, we have to take a scan with the bite in place, but we're not taking any CBCT with the device itself in place.
Cool. Jordan asked, if a hygiene patient is interested in taking a home sleep test, does hygiene hand them out? Do they do a same day appointment with Sleep Champion, or does the patient come back for another appointment?
Well, the answer, I would like it to be yes, yes, and yes, but it's not always that way. You know, at the end of the day, anytime you want to do treatment, the patient has to be ready, the team has to be ready, and the doctor has to be ready. So if one of those three people aren't ready, we can't move forward with treatment or getting started with treatment. But yes, there was a time where our hygienists were able to hand out the home sleep test, but now, what we've done in that situation is that's a lot to ask about. We already ask a lot of our hygienists to begin with. So I think asking that much more of a hygienist is probably not necessarily a great idea. So what we've done is we've trained multiple admin team members in our practice to be able to hand out the home sleep test.
Awesome. Someone messaged me again privately. They just asked, what is a good recurring training to send your team to for sleep?
Well, I think
ongoing CE, I'm sorry.
Yeah, I think there's lots of options. I mean, there's, selfishly, we have what we do at 3D Dentists, and, Chad and Mike have a great program on Awaken to Sleep. There is the AADSM. It's an organization. It's a very scientific organization, if you ask me. There's those things. There's lots of choices out there. What I would tell you is that I try to avoid choices that are trying to sell any specific type of equipment because they're going to make you feel like the equipment is necessary. And the truth is no equipment is necessary. They're very helpful, but no equipment is necessary. And then I would tell you that ongoing training is really about expanding the skill set. There's myofunctional therapy, there's adjunctive treatment, there's understanding TMD treatment, how that kind of pertains to sleep apnea. There's Healthy Start for pediatric adolescent patients. There's just so much nonstop. There's laser therapy. There's all kinds of stuff that can kind of go into this. There's learning to understand in-lab studies. There's so many things that you continuously learn. But what I would tell you is that a lot of that stuff is noise until you get a good workflow and you get a good understandings of the fundamentals.
Yeah. Paul, T-Bone, if you don't mind, I can actually elaborate a little on this question. Paul asked, do you find a lot of patients tell you that MD didn't actually explain the results of their, they don't. That's part of the medical model in that, they've got a machine that runs, they get the patient tested, reports are prepared, and they write their script for CPAP. And we have a lot of clients, and T-Bone, I'm sure you have a lot of clients as well, that dentists that you can go through that report and help them understand what T-Bone said earlier about that patient-friendly verbiage, making it understandable as a human. If you can know what the sleep test says and connect with your patients as people, you'll have a patient for life. I don't know, T-Bone, if your experience is similar to that, but
listen, these patients are so grateful and appreciative. And even if they don't do treatment, they'll refer others because you explained it to them. Look, our job at the end of the day, as much as we're talking about money and being profitable and all that stuff here, look, at the end of the day, you've got to do this to help people. And when you help people, karma pays it back to you in spades. So just help people, go into it for that.
Yeah. Awesome.